Since we're all here, let's see. I believe we're recording. So I'll just say thank you all for coming. And I know more people will come on. I will try and get the QR code up for CME credit. I have good news about this. I think we're going to be able to pay for it for everyone. So if you're not part of WashU and you want CME credit, I put in the email today the instructions. You just have to go on cme.worcester.edu and set up an account, and we should be able to cover it. And hopefully that just continues. We're expanding more and more. It seems like every month I hear about a new hospital that wants to be a part of this. So this is wonderful. I'm actually booking out through, I think my next free slot is August. So if anyone has any ideas for topics, you have plenty of time to prepare, and I'm definitely interested because I love staying ahead on this. But with that, we have Dr. Amjad Musla, part of our EM and critical care department, here to talk about trauma hematology. And with that, I'll let you take over. Thanks, Ben.
Oh, thanks for having me, Justin, and everyone else. Today, this is going to be very laid back. I basically just threw together some stuff on trauma hematology, reviewing it, and it's a lot of stuff that I didn't learn in med school, and was surprising. I actually ashamedly only learned in fellowship. So I just want to make sure is the let's see here. Let's see if the right screen is sharing. That's all. I should have done that while we were chit-chatting. Is the full screen being shared right now?
Yeah.
I'm seeing everything. It looks like most of it.
Okay, excellent. So let's go ahead and start. Here we go. 1 second, sorry. Okay, this is basically, we're going to run through memory lane. We're going to do history of blood transfusions to now. We're going to review some of the practices that we do, like basically military practices versus our BJH practices. And I'm sorry, I'm looking over to the right. It's basically my main screen's over there. We're going to look over some of the studies from the last 3 years. That was Jen Leonard's people right there. And some of this is from, they're all Pennsylvania, I guess, but some of the other stuff from the TXA and crash that I wanted to review because we seem to do things a little different here at WashU and see what other people are doing at other institutions. And then if you, what do you call it? We can finish right there, but I left ROTEM review for the last. Basically, it's one of those that some people no one wants to admit that they don't know how to read it. So I have a very simple, I'm a simple man and I have a very simple way of reading it. It takes like 5 minutes. And then at the end, you know, chatting.
Oh, sorry. Also,
go ahead.
I want to say that's super important because they are now giving us real-time access to that through the Path Labs. So if you guys, anyone on here has not received their real-time access to it, so you can like view the reader under your own account, that's helpful because the most deranged ROTEMs come through the latest on the final results. So that's access now. So that's an awesome thing, Amjad.
Thank you. No, and then jump in, please jump in at any time. This is like so nonchalant, so informal. So please jump in. If you're like, oh my God, he's making that up, say it. Okay, so let's see here. Let's click next. Okay, so we'll start off with this. To do blood transfusions, you need to invent a needle. And back in the day, they invented needles by looking at envenomation, like snakes. So they were looking at snakes and they figured out how to blow glass. And this is about 1200. In the 1200s, oh my God, some guy stabbed another dude in the eye and sucked out a cataract. His name was Amara Mussolini. And it worked. So this is the first syringe. Then Christopher Wren in the 1600s came around and he dissected animal bladders out, used that as his actual like syringe to suck things up. So you could suck things up one way, clamp a tube off, and used a duck quill or porcupine quills and hollow it out, and then they would inject it. And what did he inject it into? His lovely dog. And the worst thing that he did was, well, I don't know if it's really that bad, but he would mix opium, ale, honey, and milk and inject it so that you can see the dog stoned out of his mind or whatever's going on with this dog. But some crazy stuff was happening in the 1600s, and then he quit and became an architect. Then in the about 1600s, the first blood transfusion recorded in the oldest journal. So Philosophical Transactions. This is basically Richard Lauer. He decided to get a mastiff and a cur, and stuck a needle inside the mastiff's neck, inside the carotid, and then stuck a needle in like a vein of the cur. He drained the cur out, was about to die, and then transfused from carotid to vein from the mastiff until the cur was feeling better, stopped the bleeding, and the cur went running around, and then the mastiff died. Apparently too much blood, but did that a couple times, and it was working. So next thing he was proposing was not just doing it on dogs, but doing it from dog to human. That didn't happen. They actually were worried about dogs would cause, basically because they could be aggressive and whatnot. They decided sheep. So this is actually a French guy, Jean Baptiste. They published in Philosophical Transactions on a 15-year-old boy. They used a sheep and transfused blood into him, and it worked somehow. I don't know. That's what they reported, but 10 years later it became illegal. So it also worked in England. This is the paper that was published in England on this mentally challenged person named Arthur Koga. And so they chose him because they thought it would cure his evil humors of mentally challengedness. And it did not cure them, but he was able to report his symptoms and he had no ill effects. But 10 years later, church outlawed it. Everything became, don't do that because that's crazy. Don't transfuse human or animals into humans. Then kind of died down until the 1800s when a surgeon, obstetrician, Dr. Blundell, figured out for postpartum hemorrhage, a lady was about to die, and he devised a device basically to transfuse blood from her husband into her. It only did like 12 or 4 to 12 ounces, but it worked, and she felt a little bit better. And so 120 mil, like half a unit of whole blood. And she felt better, and no ill effects that we know of. So this is like the first real thing. Now the question to you guys comes up is, who's the universal donor of FFP? Anyone can chime in. Is it Gordon Ramsay's universal donor? I don't know. No one knows? The answers are right there. It's AB positive, and we'll go over that. So universal donor of the non-reds is AB positive. This was something I'm ashamed to say I didn't learn till like the end of residency. So let's see if this.
What's your blood type?
Wait, sorry.
What's your blood type?
How would I know?
How would you not?
Who am I, Carl Landsteiner? Discoverer of blood groups?
You know your own blood type, but you know who discovered them.
I'm ashamed to admit that I've watched Archer before. It's funny. And Carl Landsteiner, like he said, discovered the blood groups. So this was done in 1900. And the guy was a baller. I mean, he discovered the polio virus in 1909, got a Nobel Prize in physiology and medicine for his 1900 discovery. And he actually called it C, A, B, and C. These are the major blood groups. Obviously, there's a lot more blood groups, but A, B, and C are the main ones. And he called it O for, or they called it later on O for nil. So going back to that. Now, natural antigens. So type A blood. I know this is review for most people. Type A blood has A antigens on it. So your body naturally, just by eating McDonald's and chocolate milk and whatnot, just being exposed to the environment, develops these B antibodies. It's a natural antibody that exists in all type A people. Type B people that have B antigens, even without exposure to type A antigens, create this antibody, the type A antibody, literally just by being exposed to the environment. Type AB does not create antibodies because it doesn't want to kill itself. Type O wants to kill everyone. It basically wants to protect itself. So this is the review, basically the antibodies that get made. And there's also the positive and negative. The good thing for us is positive and negative, the rhesus factor. You don't naturally produce it unless you're exposed to blood. So getting pregnant or whatnot. Now, our pathology friends will laugh at us because there is a lot more blood types and things to really fully cross-match someone. There's anti-Cal, Duffy, Lutheran kit, all this stuff that way beyond our pay grade. So we're simple people. The real ones that are going to cause death, hemolytic reactions are A, B, and O. So plus and minus, we'll talk about those a little bit. So what is the distribution? We got O positive in the population in the United States. Most people are O positive. Next group is A positive. And then these are my favorite people because they have to be happy because their blood type's B positive. They're 9% of the population. O negative, so the negatives are very rare. 7% O negative here, 6% A negative, and AB positive is really rare, 3%. And this is the universal FFP donor, so very rare. So this guy should get extra money at the plasma center. I don't know.
Yeah, one thing that this will play a role into is considering RH autoimmunization when you give people whole blood and the relatively low incidence of that. There's a reasonable amount of data out of both pits. You're probably going to show it. I don't want to.
No, you're exactly right. That's I couldn't have planted you there better. Thank you.
I'm a plant, but
no.
Yeah.
Thank you. This is exactly why I'm showing this. This is very
note
important.
the super low incidence of that in the population. Not zero,
Negative.
but very low.
Yeah. So 7% O negative, 6%. What is that? 13. And then B negative is 2%. AB negative is that. So about 15 to 16%. Okay. We'll play that game. So, and then let's see who the majority of our patients in St. Louis are Caucasian African American. And when I was in New Mexico, obviously we had more Hispanic. And then in the East or West Coast is going to be, you're going to have higher Asian incidence. But I just wanted to point out where the negatives are. So A negative, B negative, AB negative again. If you notice, Caucasians are they have the most negative. So O negatives right here, 8% compared to African Americans, which are at 4%. 4% for Hispanic, 1%. And remember, females are going to be half of these people. So not very high O negative incidence, except from Caucasians. Again, A negative, 7%, 2%, 2%, 0.5. I'm really just showing this because we're going to talk about what a whole blood that we have here. B negative. Now, Asian populations, there is a difference. You'll notice that they have higher B, the B, what do you call it, blood type. So 25% here. AB negative. Anyway, just showing you guys, just pay attention to that. So the first blood transfusions. Okay, so Blundell did that, but World War I breaks out, and there's two Dr. Robertsons that come out, and then Dr. Keynes. They basically pioneer this. One's Canadian, one's from Wales, and I can't remember where the surgeon's from. It's probably British, but they pioneer blood transfusions. They use whole blood. One of them basically used a syringe from one patient to the other right away without any anticoagulation. And then Dr. Hope Oswald Robertson basically invented using citrated products. And they were using these citrated products on the battlefield and trying to get them into patients in these like forward hospitals, just kind of similar to what we're doing right now. So this is a little kit that they would pull blood out of the patient, put it in this bottle and transfer it to the next patient. And you had to know your type or else you had hemolytic reactions back then. Then in World War II, we start getting freeze-dried plasma. This is the first time we're talking about components. This is something that's coming back into vogue. I hope there's some military docs here. I haven't been exposed to this, but freeze-dried plasma was all the rage back in the World War I. They still had whole blood. They were given whole blood, but they could take this anywhere. This was the American cans, but they reconstitute it and inject it into someone. You get coagulation factors. Vietnam, we had a lot of helicopters and we still had ability to transport whole blood from Japan. This is the first time we start talking about like the triad, basically the coagulation, the triad of death, the trauma triad. This is from a old report on the Vietnam, basically military archives. So bleeding problems called variously the oozing syndrome, tomato juice syndrome, or red ink syndrome were frightening to the most experienced battle surgeon. To see a patient suddenly begin to bleed profusely from every orifice and wound, just as heroic surgery appeared to be successful, as a dramatic experience. So this goes on to talk about what the two, the coagulation problems that were, but they didn't know how to treat it back then. So one group of physicians treated all coagulation problems with fresh whole blood, while others differentiated the various syndromes and used more specific component therapy. And this is where component therapy comes in. So fresh blood, fresh frozen plasma, cortisone, heparin, Amicar, or my favorite, prayer. So sometimes when they're in DIC, that's all you can do, sadly. But this is where component therapy starts to come into vogue in the 80s and 90s. And we're starting to use component therapy, and we're splitting whole blood into all their different components. And things go back 180, back to where they were almost in the early 2000s, after we start seeing basically study after study after study coming out that's saying, hey, balanced resuscitation is the way to go, basically mixing everything as close to whole blood as possible. So this is the proper trial. This was the first civilian trial that showed 1:1:1 was similar to, this is 2 reds, 1 FFP, 1 platelets, basically in two reds. This is what kind of like showing that a balanced ratio was not inferior to this, and is actually, we're seeing that it's better and better, and we're moving towards whole blood, which that's what the military's at right now. So let's review the joint trauma guidelines. And I'm sorry, I already hear my kids coming in. So I will, if you hear me yelling, profusely sorry. So let's look at the joint trauma kind of like guidelines, basically damage control resuscitation. This is the most updated version from 2019. And they're advocating, we'll get to it, whole blood, but basically they're shooting for, telling us target when you're resuscitating a blood pressure around 100 millimeters. So permissive hypotension, they added that to their little thing, their updated guidelines, and monitor your INR or other coagulopathies. So let's see what they're talking about over here. They advocate for the use of REBOAs and tourniquets. So this is to reduce hemorrhage. I've not put it to REBOA here. I've seen one in my whole life. So I was curious if a lot of you guys have done REBOAs or anything like that instead of cracking chests open.
Well,
Anyone?
I mean, my opinion, and anybody else feel free to join in on this. So REBOA is for people who are alive, and ED thoracotomy is for people who are dead. And comparing outcomes between alive and dead patients invariably gives a preference to one. So this initial study between ED thoracotomy and REBOA were just poorly done. Now, I think the pendulum is really swinging against super aggressive REBOA, except in certain circumstances. I think it's fairly accepted for really bad pelvic fractures and whatnot. But I think we're, as a field, leaning away from REBOA, because as you get it more widely used, the incidence of limb ischemia and clotting and all these other things downstream of it are much higher. And in order to be a really successful REBOA center, you basically have to get a really good arterial access. You can't just shove an art line in everybody that comes in. It's got to be not in the SFA, in the right position, ultrasound guided.
Perfect. You got to be super fast at it.
Yeah, and it's got to be good. And I think that the complications, as a institution, we're not as a field, we're kind of moving away from it, except for really bad pelvic injuries where IR is potentially a ways away.
And I'm curious, are any of your like military colleagues, are any of the military colleagues, like is Charlie or anyone here?
I will just say that I've been after this topic for a while to have us discuss at this conference. And the problem is our guru, Jerry Fortuna, left. And before he could give it, if anyone wants to back up REBOA and defend it and give a talk on it, I would love it. And I think it would be great to hear, because we don't have that voice of positivity about REBOA anymore.
I'm pretty sure we could find someone from shock trauma, given all of the inroads that the division has, who would wholeheartedly support it. So we could come up with that.
I do see one of our shock trauma representatives on, and I know he's one of our anesthesiologists, but we can throw that to them and see if they want to step up in the next year or so and tell us all about REBOA and why we should be using it. Because yes, I agree with you, Amjad. There's a reason you haven't seen it. We don't use it very much anymore.
Yeah, is shock using it? Is who's using it? I guess is the military actually using it? That's what I'm curious.
I don't know that the military. I don't know about the military use of it, but you have to understand that once you put a REBOA up, you have to have a definitive surgical center pretty readily available. You know, like more than 60 minutes of Reboa is probably pretty lethal. And so, you know, they're not using it out in the field, you know, when there's a large transport and those kinds of things. But that's something that would be interesting to hear about. And Justin, I can send some feelers out to see if anybody else would want to have a discussion about that.
That would be
Jeremy
fantastic.
Cannon might be a good one. Jeremy Cannon at Penn might be a good one.
I'm not an attending yet, but I can maybe comment. This is Maggie, just coming from, I'm one of the active duty fellows, but we did some Reboa research where I did residency and worked in the Air Force lab doing Reboa research. And as of at least a couple of years ago, they're definitely still advocating for it. It's still within our TCCC guidelines. If they're at that point still putting it up and putting people, you know, on helicopters, I don't know how often that's actually happening, but that's definitely still something that they're talking about doing. And then you just have to get them to a place that they can get operated on, exactly as Dr. Leonard was saying, within like 60 minutes. And that's just kind of something that they're still studying. But as she mentioned, if you're, you know, high up in zone 1, then you're going to cause a lot of problems if you don't address that really rapidly. So sometimes something that they're looking at is like partial Reboa, or even using it more as like an adjunct in like somebody who's hemorrhaging that you're like taking immediately up to the OR. So anyway, that's the last I've heard of it in the military.
It was just interesting. I just like to see what they write different than we do, because I haven't trained on it. I don't know anything about it. So thank you guys. Okay, so the next thing that I've noticed a little bit different, wait, let's go back here, slide, is their ratios. So they like whole blood. We like whole blood. Everyone likes whole blood. The whole blood's really nice. I'm going to talk about it, why. But their ratio includes cryo. They're 1 to 1 to 1. And I'll talk about our Barnes and curious to see what other institutions are doing, but we're not doing 1 to 1 to 1 to 1 based on this. So that's something that's interesting and will pop up here in a sec. The other thing that they're doing that we seem to like lost favor here at our institution is they're still pushing really hard for TXA based on Crash 2. And even Crash 3 is like low TBI injury data that we'll cover. But it seems like over here at Barnes, there's a little bit of issues, or some people don't like it, but it's still on our guidelines. So I'm curious to open up that can of worms here in a second. I'll show the studies and we'll open it up in a sec. The other thing that I like about them, this is kind of, I copied their protocol back in the day when I was a fellow for our trauma ICU on calcium. So 1 gram of calcium on the first unit, and every 4 units you give 1 gram of calcium, or 30 mils of 10% calcium gluconate, so 3 grams of gluconate, if that. Who, just for funsies factors, which product has the most citrated or most anticoagulants in it that's going to consume all your calcium? Is it red blood cells? Is it cryo? Is it FFP? Is it platelets? Does anyone know?
Plasma.
Close. What's a bag of clot? It's getting agitated at room temperature. It's platelets. So plasma is right next to it. So what do you call it? Because it has all the factors, but you need the platelets to make that big, chunky, nice clot. So it has a lot of anticoagulants in it. So it'll eat up your calcium the most. But plasma is right next to it. So let's see what comes in our MTP box. So this is why Dr. Leonard brought up trauma, MTP, RH positive issues. One thing I want to point out to you guys is we do have O negative trauma MTP. It just depends on availability. There is, most of the time, based on the blood bank's capabilities, and if anyone from blood bank can chime in, if any of the pathologists or hematologists are here, I would love that. But you can see here, we have trauma whole blood MTP, that's ORH negative. Remember that for your females that are less than 50 that we're running that. Most of the time, this week we have ORH negative. We have both boxes of trauma MTP. So you can run a trauma MTP for a female that you don't know their RH status. It doesn't matter in men because we're not going to get sensitized to it and cause high drops later on or some other issues. So O positive is just fine for men, but O negative would be preferred for females. So we know for sure we have two types of MTP. So let's go through our MTP. We have trauma MTP. You have 2 units of whole blood sitting in the ED. You have 6 units in a cooler, just waiting for you to ask for it. The second you open the fridge, this is the ED fridge, there's a red phone that turns on. It's right on top of, this is the middle area in our ED where all the consultants write their notes. So the fridge is right there. The second you pop it open, the phone rings and they're like, what's going on? So you can tell them we're activating MTP and you tell them if it's a male or female. So you yank these 2 negative, these O, usually it's positive, but we have ORH negative. This was from last week, and this week we have ORH negative. So you yank these out, you give them to your patient, box 1 comes, you got 6 units of whole blood. And we're gonna talk why this is important, 6 units of whole blood. Box 2, every 30 minutes, they're gonna send you a box. You gotta tell them where you're going, if they're in the OR or not, or the ICU. Box 2 gets you 6 units of reds, 6 units of FFP, and 1 unit of platelets, which is 6, equivalent to 6. The only, and box 4 and 5 and 6 and so on are going to look just like box 2. The special box that we have is box 3. Box 3, because it takes forever to thaw out some cryo, it has 10 units of cryo in it. That's the only difference in addition. And we only get cryo here. Now, I'm going to bring up why this is a big deal. 10 units of cryo, and that's all you're getting. So we're not running 1 to 1 to 1 to 1 the way the military is doing it. And this used to be our old MTP. So this is, if you ask for standard MTP, let's say trauma MTP, it's RH positive and you're really worried about this female and you don't want to give RH positive blood, so you can run your standard MTP. Box 1 gets you 10 units of reds. I don't have a good explanation for that, but that's what box 1 has. 6 units of FFP, 1 unit of platelets. Box 2 is similar to box 2 here, and box 3 is similar to box 3 here. So really the main difference is the first box. You get, and I really don't know what's up with the 10 units. If anyone knows or was around during those meetings, is like Doug around or anyone? No? Okay, I'll carry on then. Okay.
I will say,
So-
Amjad, just so we're clear, on March 1st, we're switching to balance resuscitation. So we'll go 666 or 661 starting on March 1st.
Yeah, Dr. Watson's here, so thank you guys. So Brendan shared some info. Brendan, I'm just gonna say there was about 300 activations. Is that okay, or is that like should I not share that yet?
That's fine.
Okay,
That's
just
about
that.
that's in the past 2 years we have about 300 MTP
Activations in the past, and then we don't give a lot of cryo here. We're going to say that Dr. Watson's going to present some research stuff, but since this is multi-centered, we didn't want to give out too much details, but we underdose cryo. And that's a couple things that I think, Brendan, are you going to be talking soon on anything about it, hopefully?
Yeah, I'm hoping in the next few months we'll be able to get something together and I'll talk to everybody about it.
Yeah, so hopefully we'll even research it, but let's go over why whole blood's important. So this is a study from Journal Anesthesia. Basically, they are comparing whole blood, and thank you, Brendan, for a lot of these resources from Brendan. They basically studied whole blood from a patient versus reconstituted blood, and they just looked at the platelets, hematocrit, and everything in it. So let's look at it. So they basically drew out your blood and without coagulation and did a cell count on it. So just to see what your normal hematocrit is. This is your normal stuff. Then they basically got a regular anticoagulated tube and to look at your coag factors and everything, your blue top. Then they sucked out some units of blood from volunteers and compared it to reconstituted blood. So let's go over that. So I wanted to point out these two different, we have FFP at our institution. Other institutions have liquid plasma. And then this is the cool stuff that's being deployed, like the French are doing and the World War II used to do, but the French and I think Netherlands has this. I can't remember, correct me if I'm wrong, but they have freeze-dried plasma. And so the military finally got it for the special forces, supposedly. And if any of you military docs are on here, can you tell me about freeze-dried plasma? But this is, they reconstituted and compared it. So this is component therapy versus whole blood therapy. So we're going to look at what it looks like. Maggie, did you ever use any of this?
No, we didn't use any of that where I was, but I also haven't actually been
deployed yet, so
Oh, okay, my bad.
that, no, I was just giving, I had just done research for Rabo in the military. That's what I was commenting before, but
Okay, let's see here. So what does whole blood look like compared to reconstituted blood? So this is the patient's like non-coagulated, their actual hematocrit. This is basically the blue top, and this is their actual whole blood hematocrit. So it's a little bit lower. It's not like exactly because there is some anticoagulants that go in and dilute it a little bit. Now let's look at whole blood or reconstituted from PRBCs, like 1 to 1 to 1. This is the hematocrit. So you get about 29% hematocrit when you reconstitute all the components because of all the dilution factors, all the dilutants that go into basically your plasma and your platelets and your red bloods. Well, the red blood cells are drained, but all the dilutants that go into reconstituting everything. And plus we actually like mix saline into it while we're resuscitating anyway for the blood tubing. So let's look at their platelet counts. Again, this is the patient's native. This is what their fresh whole blood donation would look like. So the platelet counts are above 200s. And when you reconstitute it, it's around 90,000. So it's less than 100. Not great. So this is from 1 to 1 to 1. Now let's look at their fibrinogen and levels and everything. So fibrinogen levels, basically, this is the whole blood right here. It's really good. You know, it's above 300, like it's near 300. And then this is where we get shady. This is the reconstitution. We're under almost like 200 already. So it's usually around 190, 160, somewhere in that range. And we're transfusing at like 160 anyway. We're trying to give cryo and stuff like that. So you're already starting low, even though I was taught in medical school that FFP had cryo, or not cryo, fibrinogen in it. So it's weird. Totally unrelated, but like this is pretty shocking to me, like how much you're already starting very low and we're not giving cryo till the third box. So it's just something to think about. Quick question for you guys. What's factor 1, by the way, in the clotting cascade? You get super brownie points for me if you know it.
Fibrinogen.
Yeah, it's kind of one of the most ignored things, and it's important. So this is a study that's hopefully coming out from England soon. They're basically looking at doing fibrinogen early on, or cryo early on, sorry, in their activations. And they need one more patient. So Brendan, I checked the website today and it's still one more patient. I don't know if they've got that patient, just haven't updated the website, but it's just waiting. So hopefully we'll have some data on whether early high dose cryo or like 1 to 1 to 1 really works in the civilian population. So let's go back here. And then this is something that was pointed out to me by Brendan as well, is we don't even check it when they first come in. We look at their urine drug screen. Like, I don't care really if they're on coke, because most of our patients, a lot of them are on drugs, but it doesn't really affect clinically, but we're not checking it for some reason. So we're basically doing a fib temp. That's the closest we get to it, but we're not really checking it. So just to recap, trauma whole blood most of the time is O positive here. So if you have an O, basically a female, be cautious. Think about it. Ask if you have O neg. If it does, then who cares? That's awesome. Let's run the trauma MTP on them. But if they don't, then think about it. And because you don't want to sensitize a patient and cause problems down the line. And let's say it did happen, I would talk to hematology and consider RhoGAM and OB consult, because RhoGAM basically hides the antigen and it gives it it lasts 12 weeks in your bloodstream and hides it hopefully longer. But when you're getting trauma level blood, I don't know if it can hide enough of it. Fibrinogen is low in 1 to 1 to 1. This is the recap I wanted to throw out there. It's factor 1 and we don't care about it. Pay attention. What I'm advocating is let's draw the labs. Let's check them every hour. Let's look at it just as we're doing our damage control resuscitation. And then pay attention to your calcium. This is protocolized. I haven't been in 44 for a few months, so I haven't seen if we're keeping up on giving calcium, but sometimes in the ED we get lost and we don't give enough calcium. I hope in the ORs you guys don't get lost, but I'll defer to the anesthesiologist in the room. The other thing that I noticed that we do here that sometimes could be better is we don't monitor the temp. Like, we report all the vitals, but the temperature we're not paying attention to. And it's not until like we've done the trauma handshake in the butt that we are like, oh, we should probably cover them up right now. So just reporting it might be enhancing our ability to keep people warm. Questions? Enough breather time?
Just on the calcium comment, you had mentioned, fibrinogen is factor 1, but calcium's not far behind. It's factor 4, and it's needed for like basically every portion of the coagulation cascade pathway. So getting behind there can really kind of mess up your coagulation the whole way down. So it's something to keep in mind and stay on top of. And it's not part of our MTP protocol at all, or MTP as far as I know.
Yeah, they have a protocol upstairs in the SICU. It's on like the what do you call it? It's on the crash cart, but I don't know how well it's being used or not. But down in the ED, it's kind of like when we remember.
Jad, we're definitely pushing it from the anesthesia side in the OR. In
Gotcha.
trauma, and I'm hoping we're going to have a talk on this in the next few months from one of your ED colleagues who published on it. So I'm in the works of scheduling that.
Since I have you, Justin, Belmonts and platelets. So I didn't learn this till fellowship, but are we not supposed to use any kind of pressure on? I'm reading from the blood bank, basically on cryo and platelets. Platelets I understand because it crushes it, but is that true? You can't dump you have to let them run separately?
I'll try and talk around the screaming child. The Belmont company will tell you cannot do it. Anecdotal evidence from other places around the country, they do it. I know I saw Justin on earlier. I'm curious what shock trauma does. I will just say anecdotally, I had one case in the OR where I had some white precipitate form in the tubing in front of my eyes after I dumped everything in the Belmont, because my understanding is that you can put everything through. And since then, I've just kind of been very wary about it. We've also had a couple case reports about hypotension with Belmont use. And it seems separate from blood loss, but something about actually running the Belmont. And we're not the only place that's seen this. I think Mount Sinai and New York had seen it, and UCSF has seen it. So there may be more to this about whether this is really okay. The Belmont guidelines will tell you don't do it, but I've heard the same thing, that you can.
Yeah, and then the other thing that blood bank threw me off, I don't give cryo myself, like the nurses always do it, but you're not supposed to warm the cryo or else it basically loses its efficacy, and it's supposed to go in not through the Belmont. So that was new to me, unless you guys give it. So what do you do?
Normally we're giving it as soon as we get it.
Okay, so you're just running it in, but you're not like warming it up or anything.
No.
Okay, cool. So this is Leonard's people right here, UPenn, and they basically did a really cool study. It's small numbers, like they randomized 49 patients to vaso and 51 to placebo, but basically they wanted to see if running vaso until the surgeon says the hemorrhage is controlled, making it not titratable, just turning it on, giving a bolus first. Once you activate master transfusion, they would give a bolus of vaso. 4 units seems like a pretty damn good bolus. And then 0.04 standard drip until the surgeon says, hey, we have enough vitamin P, proline in the body, or whatever surgical material they've used. And then they tell you can titrate it for the next 48 hours. And they also okayed the use of levo on top of the vaso if you needed it. So it was a randomized placebo double-blind control trial at a Penn. And this is what's interesting to me. So even though it's small numbers, this got my attention. It looks like basically this is how many liters of blood products. The vaso group had 1.7 in 48 hours, 1.7 liters, and then 3.0 liters for a p-value of 0.03 for the placebo group right here. So that's pretty drastic numbers to me. I don't know, but based on this, I'm like using it. Now the thought process is vaso can activate platelets. So there is some concern that it would cause DVTs and clots, but there's something interesting that I'm going to show you in a second here. What threw me off was this. Do you guys think we use this much crystalloid in our ICU? I hope not. Like 9.7 liters, 10.7 liters in 48 hours. That's a ton of crystalloid. I don't know. I've never actually looked it up in our ICU, but it seems like an insane amount of crystalloid. And this is what their norepi infusions look like. Basically, how many micrograms of norepi was used if the vasal was on, much less norepi than if the vasal wasn't, which makes sense. But this was very interesting. Like that's a lot of saving on products. The adverse events. So DVT I thought was going to be higher in the vasal group, but it wasn't. It was surprisingly lower. Now the numbers are very small. They're not like significant, but this was just surprising to me. And the complications they were the same, like normal stuff you expect. So they got ARDS in both groups. They got VAPS in both groups, but the DVTs threw me off. So that was interesting to me. So I don't say it's like prime time, you have to use vasopressin, but it's pretty cool. And I started using it after I saw this back in the day. So I give it a seal of approval. Now, the next study is the COMBAT and PAMPER. They did a post hoc analysis. So COMBAT was basically ground transport and looking at pre-hospital plasma. So I wish we had a cool ground transport like that. And then this is where I used to fly in New Mexico. And I was on this exact helicopter and we had plasma too, and red blood cells. So the cool thing about this was basically they did PAMPER, which was the air medical one, and the COMBAT trial, and they looked at basically pre-hospital use of plasma. Now, the catch here is we have fresh frozen plasma at our institution, and so that's not very viable for ground medics and air medics and stuff. So you have to use the other plasmas I showed you, like the solvent or the liquid plasma. So you just need a blood bank that's going to be willing to give that to your groups. The other thing here that we probably couldn't do similarly is none of our agencies are owned by WashU. Actually, literally run through WashU like it was in New Mexico. We are medical control for them, but WashU wouldn't be. I guess there would have to be an agreement to give the blood and stuff like that. And but anyway, what's the data? So let's look at the data. So in general, if this was your likelihood to die, your odds ratio of dying, and with getting plasma, you did better than getting standard of care. Now, if you got plasma very early, your transport time was amazing. They did scoop and run or a diesel bolus, really, really fast, get you to the hospital. The plasma group probably didn't do as good. So they didn't do as good if it was less than 20-minute transport time. I don't have a good explanation on it, but not as good. When the transport times were long, just as you expect, giving coagulation factors back to the patient, they did better. So this was their general, it's 626 patients total, and they had a 20% mortality in the plasma group and a 28% in the non-plasma group. So most deaths were in the first 6 hours. So I like this. I like pre-hospital giving, I'm an EMS person and I like giving pre-hospital people tools, but I'm going to, hopefully the FDA will finally approve freeze-dried plasma and make this more viable, because even the liquid plasma only lasts 21 or 26 days. Any questions on that? So basically pre-hospital blood, sooner you get blood, hopefully will help if you have long transport times. But this wasn't blood, this was coagulation factors. I'm hoping they're doing trials already on blood. Questions, comments, concerns? Lots of concerns. Okay. If none, then we'll move on. Head injuries. So this is something that always freaks me out. Basically, it's always old ladies and falling. Old ladies and falling. So I always wonder how many CT scans do I need to scan these guys for? And our friends at UCSD did a nice little study. They basically did a retrospective look at all their CT scans, people that got 2 CT scans. They had their protocol was like, you got to scan when you first come in, even if it's negative, if you're on any antiplatelets or any blood thinners, you got to repeat CT scan in 6 hours. So they recruited, or they looked at 1,377 patients, and most of them were falls, just like our GTS population. Most of them are falls. And basically, this is the distribution, like what kind of anticoagulants they have. Some people had mixed aspirin and Plavix, and some people had mixed aspirin and warfarin and stuff like that. So, and DOACs and all of the different ones. But they did basically, how many head bleeds did they find that were negative on the first and positive on the second? Just 12. 12 out of 1,377. And my favorite thing is none of them required neurosurgical intervention. And I don't even know if any of them would have been caught. So my question for you guys is, how many of you guys get repeat head CTs when you're the trauma attending upstairs?
I can kind of answer that for you, Amjad. I did a retrospective review on this, and I looked at every DOAC patient who had come in with a fall at our institution from the initiation of DOACs until I did it in residency. So it was like 2017, 2018 sometime. And we had 0 delayed head bleeds found at our institution in patients on DOACs. So the answer is we did about 20% of them did get repeat CTs, 25%, but none of them had bleeds.
The most interesting part about it, Brendan, is it cost them basically when they did the money analysis just for the hospital itself, it cost them about $1 million. So I'm sure they rake the money in somehow. I don't know how much money they made off those head CTs, but it cost them $1 million on those extra head CTs, and nothing really changed outcome wise. Now I'm going to open up the can of TXA worms, and basically let's just review how it works. So it binds plasminogen, and it can inhibit. So TPA binds plasminogen, activates and breaks down clots. So you get these fibrin split products right here. This guy just goes into the lysine binding site, sits there, and doesn't let it work. Now, as an ER doc, I love anything that lets me do stuff. And so it's become like the most magic medicine in emergency medicine. Like we use it on everything, but I don't know if it's that great. We basically use it for nosebleeds. We use it for mouth bleeds. We soak it on the rhino rockets. We use it for postpartum hemorrhage, which it's initially approved for. We in the ICU use it for diffuse alveolar hemorrhage, and they nebulize it sometimes in the MICU. They'll even use Amicar and similar stuff like that. It was discovered by this young lady right here, Tako Okamoto, in the 50s. And basically she was doing she was a doctor, MD, but also doing research in Japan on cerebellums. There wasn't that many cerebellums in World War II, and not many supportive people of women at that time. So she decided that she couldn't get funding. She decided to switch over from cerebellums to studying blood. And she had free access to blood because she could draw her own blood and her husband's blood. So it was cool. And she basically discovered TXA and that it stopped fibrinolysis. And later on, she died right in 2009, right before, Crash 2 came out. So she was hearing about it and how everything, but Crash 2 came out and it was the craze, basically. It was a massive overseas kind of study by the London School of Hygiene guys. They had basically 40 countries, 274 patients or hospitals, 20,000 patients. And it was double-blind randomized control. And they basically had really good outcomes. They had 1.5% mortality or risk reduction of death due to bleeding compared to the placebo. And it became the craze. Like when I first got into residency, that was the cool thing to do. Number needed to treat was 67. They gave it to everyone. Then Crash 3 came out later on in like 2019, and they did it for head bleeds. Like let's say, hey, or head injuries. Does TXA help out for head injuries? And it was again double-blind RCT with 175 hospitals. These London guys are just, I don't know how they get these massive studies going. They ran it for 7 years, and they recruited anyone with a TBI or GCS, what they suspected was TBI, GCS of less than 12, or a bleed on the head CT. No major external bleeding, and the doc had to be like, I don't know if we should give it or not. That was a recruitment criteria, and it was blinded, and they analyzed 4,600 patients, and inside the TXA group, and 4,500 in the non-TXA, the placebo group. Now, what they found out, it wasn't really overall beneficial, the actual, like just giving it to randomly. But for mild TBI, so if your GCS was 9 to 15 and both pupils were reactive, there was some favoring towards TXA, some signals that it decreased 28-day mortality. Then there's subgroup analysis on that. Basically, the sooner you gave it, this is time, and this is the risk ratio. The sooner you gave it, the better. So the big question is always like, does it cause clots and everything like that? Crash 2 didn't show any big increase in DVTs and everything, and neither did Crash 3. So not very scary. But Jess Kramer and our group here, Dr. Schur, looked at how much hemolysis or like fibrinolysis is actually happening here in our institution. And 2.2%. So not much fibrinolysis. So I've noticed that a lot of our trauma colleagues don't like or don't advocate for TXA. And then 2 studies came out recently that didn't really show any pre-hospital studies. So they're getting it very soon. Didn't show any benefit for TXA. But the patients in it weren't really severely injured as bad as the crash patients. So my question for you guys is, it's part of our protocol. So if you go to the website right now, the Worcester website, it says we give TXA, but I've noticed a lot in the trauma bay that people are against it. So what's your guys' thought process on it?
So I'll just say right off the bat, I think we need to talk on this, and I have some people in mind to give it. I was on the same impression as all this is, we don't see the fibrinolysis. We're smarter than the crash studies because we have ROTEM. We can look for fibrinolysis. And the one thing that kind of brought me back to it is seeing some of Marty Schreiber's work on this out of Oregon. And I think it was his group that showed that the ROTEMs did not actually change that much when you gave TXA. And so the question is it working the way we think it's working, or is it doing something else? And if it's doing something else, then we possibly should be giving it. And until we kind of understand what that is, that's guided me to give it a little bit more than I used to before. So that's the only caveat I think we're putting all this on the ROTEM and basically assuming that we know more about TXA than we may. And we may be wrong on some of this.
I'm in the same with you because where I trained, it was just God, country, and TXA. So it's just like I'm curious what anything from the trauma guys.
I'll add real quick from the ICU perspective. We've seen enough seizures, especially in the cardiothoracic unit, to be wary of giving it. And so I'm really torn on it because I definitely have seen both sides, and we've seen it from ortho cases. We've seen it in the CT ICU. It's not something.
Yeah, it crosses the blood-brain barrier, and it looks like glutamate. So it basically blocks those receptor sites. Right. So yes, it can cause seizures in decent dosing.
I'm not willing to hang it, with the calcium and vaso yet, but.
Hey, Justin, just, if I can share a couple thoughts, because this is a really interesting topic. And I have to admit, I rode the TXA seesaw for a while, depending on whatever was kind of coming out at the time, whether it was crash 2, then crash 3, and then the pre-hospital stuff. And here in reading Marty Schreiber's paper, just like you mentioned, and they advocated for this early TXA, and it's beneficial, it has to work, only to publish that in their trial it didn't work, which was frustrating. But nonetheless, when you read this Frank Guyette paper, which I think is where it seems to be the money is right now, they found a pretty big difference in when you get TXA within an hour if you were hypotensive. And that seems to be the population where there might be benefit. And I agree with you that I don't think we know how it works to provide benefit. I don't think it's the fibrinolysis. When we looked at it in our data, in fact, people who with fibrinolysis who got TXA had more mortality and more organ failure. It's probably because they were sicker. But I think this is just an example.
This is the part Justin's talking about right here. Yeah. So like the 1 hour group this is the subgroup that they were talking about.
And my suspicion is that's why Marty Schreiber is advocating for it so early. It's just we really have this one small subgroup to go off of. I don't buy that the 1.5 percentage point difference in the crash 2 trial is clinically significant, but that's what, I mean, I'll be honest, the obstetricians, the obstetric data is the very same thing. They say, oh, this must work because it's a 1.5 percentage point, actually less than 1 percentage point difference. But I think we got to look at what the effect size is.
Well, and I think that's part of the problem with this is if this is right, then we have an hour to give it. And we're never going to get a ROTEM back that quickly.
Well, and the other part is here we're trying to, there's the advocacy for getting it on the helicopters, essentially giving it to everybody pre-hospital. And I don't think that's the answer because I think you're going to run into more complications, specifically the seizures like you talked about. I think we just have to be really thoughtful in who we do it on. And there's still a lot of questions about it.
Yeah, this is why I opened up the bag of worms. I don't know. By the way, I do have Rotem slides, but I can cover those for whoever wants to like hang out later on. So I think we've reached like an hour. But I really am curious on like, should I be writing I think there's something we don't know about it. That's where I'm at right now. So I do give, I don't know if 2 grams have caused me any problems ever for me personally, but I have seen the seizures, like you said, in the CTICU. And some of that's a bias because that's how I was trained too.
Can you preload with Keppra and avoid the seizures?
I don't know actually. The seizures aren't as bad as you would think. So the one I've seen was terminated with Ativan, but that's a good idea. I don't know, Justin.
I have no idea. I'm scared if that works because then it just opens up the door for everyone to throw more TXA at people.
Oh, I just opened up the chat. Jamie, for me, I was always taught the sooner you give it, the better. So like, just like the subgroup in this last study on the bottom screen, they got it within an hour for the very sick patients and they did a little bit better, but that was a subgroup analysis the study wasn't powered to do.
One of my other thoughts just to share with TXA, this kind of goes back to when we started looking at our TXA fibrinolysis and whatnot. I think if we're hedging all our bets on TXA as the magic bullet. By the way, people don't die of a TXA deficiency. But if we're thinking TXA fixes everything, we're missing a lot of the coagulopathy that's going on too. Because if we think it's the fibrinolysis, that's one small part of a very big and very different coagulopathic picture in every patient.
Yeah, any comments, anyone else, any questions? I don't know if there's a downside to Keppra use, man. Like that's actually, what isn't, I actually don't remember the mechanism. Is it a sodium channel blocker?
Ouch, can't remember. Got to look it up.
So Amjad, for the interest of time, I may say, how about I invite you back to go over Rotem and how we use it?
Yeah, no, for sure. I think, yeah, this is too long to do Rotem, I think later on.
Yeah,
it's a fun little it's easy, but this is way too long. Like there's only like 2 minutes or a minute. Yeah, I guess my summary is I don't know the answer for TXA. I'd like vasopressin. Please check your fibrinogen levels. Please give calcium. And I don't care if you get their iCal to 5.2 or whatever, it will self-resolve. There is one thing to pay attention when we're using component therapy is a lot of our red blood cells are a little old and some of the hyper K that you see is from red blood cells being lysed. So if you notice that, pay attention to it. So keep them warm, give them cryo or fibrinogen, get fibrinogen in them somehow and check it, at least just check it and give calcium. And I hope that the blood groups was a little fun.
Well, I'll just start by saying thank you. I think you have about 5 topics here that we can definitely dive into, and hopefully we will over the next few months to a year. So thank you for all that. It was a great review of all of that. And yeah, I think you brought up a lot of great points that we definitely need to figure out a lot more that really impacts our practice, whether it's the TXA, whether it's the vasopressin. That's something I push very heavily for because I think it makes sense, but we'll fully admit, I don't think we have all the answers. So thank you very much for that. Does anyone else have any questions? Anything? I'm going through the chat. I think we covered a lot of that. Does anyone else have any questions or comments they want to add?
I had a question for the group. Just out of curiosity. So I'm noticing that sometimes we have ONEG, sometimes we don't. Any of you guys, what do you call it? Like know the rhyme or reason? Is it just our supply and demand when we have the ONEGs for the whole blood?
I'll make a quick comment. I think it is supply and demand. That being said, we're hopefully going to have a talk from Dr. Grossman from the blood bank in the next couple months. I think July I have it set. And to talk, I brought up that as a specific topic as, how do we deal with supply in a blood bank for a trauma center as busy as we are? If anyone else has comments that may know better.
And remember what Brendan said, in March 1st, we're going to 1-to-1-to-1, actual 1-to-1, not that 10 units at the beginning.
All right, well, if there are no other questions, we're at an hour. Thank you again, Namjad. And yeah, I'll get back to you about doing some ROTEM work, and we'll see if we can have you back on. Thanks, everyone.